Swastiastu, we are from Group B6 and we will present our student project about invasive pulmonary aspergillosis. I'm Angelica Fatnangawan as the moderator with the last year student registration digit number 092. Now we will present the introduction. To the first presenter in charge, you may start.
Hello, my name is Kadek Bintang Aristia Putri with my last year digit of my student number is 056 and I will explain about the background of this paper. Indonesia is a tropical country, warm and humid, with numerous environmental fungi. One type of fungi that could cause infections related to lung disease is Aspergillus. The annual incidence of invasive aspergillosis in Indonesia was estimated at 49,500 cases, and the most predominant examples of invasive disease that affect immunodeficient individuals is pulmonary aspergillosis. One type of the categories is invasive pulmonary aspergillosis or IPA. IPA is a severe acute or subacute disease that could be found not only in neutropenic or severe immunocompromised patients but also in non-neutropenic patients. Patients with no classical risk factor of IPA has reported a high suspicion of infections in non-neutropenic patients because the clinical presentations is silent and non-specific. It makes the diagnosis of IPA often delayed and increase the rates of mortality of non-neutropenic patients. Despite the challenges, new diagnostic methods, imaging techniques, and therapies continue to be explored in order to reduce patients' morbidity and mortality. And the problem formulation of this paper is what is the definition of invasive pulmonary aspergillosis, what are the epidemiology, etiology, and pathophysiology of invasive pulmonary aspergillosis, and what are the treatment and management of invasive pulmonary aspergillosis. That's all from me, and the next slide will be presented by my friends. Thank you.
The objectives are to describe the definition of invasive pulmonary aspergillosis, to explain the epidemiology, etiology, and pathophysiology of invasive pulmonary aspergillosis, and to know the treatment and management of invasive pulmonary aspergillosis. There is theoretical benefit of this paper. This paper can be used to increase knowledge about invasive pulmonary aspergillosis, its epidemiology, etiology, and pathophysiology. In addition, it can add insight about the treatment and management of invasive pulmonary aspergillosis theoretically. There is also practical benefit for readers. This paper are being a source of information regarding invasive pulmonary aspergillosis. For writers, it's to increase the experience and knowledge in writing scientific works. For academic institutions, it can be used as a reference to develop knowledge about invasive pulmonary aspergillosis.
Greetings evaluators, my name is Janice Geraldine with the last three-digit number 119. Aspergillosis is a spectrum of infections caused by fungi from the Aspergillus genus. The species most involved are the four species shown in the slide. The forms include, number 1, pulmonary aspergillosis and rhinosinusitis, and are the most prominent examples of invasive diseases. Other more indolent forms, such as chronic pulmonary aspergillosis or CPA, aspergilloma, and ABPA, which often occur in patients with underlying lung diseases. And the last one is there is cutaneous aspergillosis that is often seen when wounds in immunocompromised patients are inoculated with aspergillus. Finally, this activity reviews the evaluation and management of aspergillosis, which varies significantly depending on the clinical syndrome, and highlights the role of the interprofessional team in managing patients with this spectrum of conditions. That's all from me. Thank you.
Before I continue, let me introduce myself first. My name is Devalizar Ramadan with class number 060. Aspergilloma, chronic aspergillosis, and invasive aspergillosis represent distinct clinical manifestations of Aspergillus fungal infections. Aspergilloma, also known as fungal bulb, lymphadenitis aspergillus is typically found within pre-existing lung cavities or bronchitic airways. It often occurs in individuals with bare lung damage. Chronic aspergillosis encompasses a broader spectrum of chronic pulmonary infections caused by Aspergillus species, affecting individuals with underlying lung conditions like chronic obstructive pulmonary disease. Invasive aspergillosis is the most aggressive form, characterized by infection Aspergillus into vital organs and bloodstream, predominantly affecting immunocompromised patients. It is life-threatening condition associated with high mortality rates if not promptly diagnosed and treated.
So hello everyone, my name is Adelia Pramesti with the last three-digit number 165. So let's talk first about the role epidemiology. Invasive pulmonary aspergillosis has been recorded with estimated over 300,000 new cases worldwide each year. 10 million people are at risk of experiencing IPA, and death rate or case fatality rate is 80% from all of the reported cases. Aspergillosis itself is caused by Aspergillus. Aspergillus has various species, but the most significant are A. fumicatus and A. flavus. According to the geography, A. fumicatus is common in Europe and America, and while A. flavus is common in Asia, Africa, and the Middle East. This is due to A. flavus' ability to withstand hot climates. IPA is known to affect more people with impaired immune system. It is known to be the second most common cause of acquired lung infections after pneumocystis in AIDS, with its incidence reaching 19 per 100 people, calculated from the 90s, but nowadays it is starting to decrease by the use of antiretroviral. Apart from that, the most frequent conditions that cause IPA's comorbid are acute myeloid leukemia or AML and myelodysplastic syndromes (MDS), with the incidence reaching 24%. Patients who get treated for long periods in the ICU or with severe medical conditions are also at risk of experiencing IPA, with the incidence known to reach between 0.3% and 19%. Moreover, 19% of IPA cases occur newly in patients who have undergone transplantation, especially lung, with a median occurrence by 6 months post-surgery. IPA is also known to complicate in 35% cases of COVID-19 patients in ICU. Most of the data is coming from European countries. Patients with COVID-19 associated pulmonary aspergillosis or PIPA have been reported to take corticosteroids, which is known to increase fungal infection risk. Similarly, the incidence of IPA is also increased in autoimmune patients owing to the fact that they are treated with corticosteroids. Moreover, latest research shows that patients with liver failure are more likely to experience fungal infections, including IPA, with the mortality rate reaching 71.6%. In addition, investigation held in Taiwan showed that the galactomannan test can raise the incidence of IPA.
Let's talk about etiology of aspergillosis. So it has different routes of entry. Depending on the routes of entry, it could cause different clinical syndromes, right? Let's talk about the most common route of entry for aspergillosis. That being said, is via breathing or respiratory tract. So firstly, let's discuss about pulmonary aspergillosis. Inhalation of Aspergillus conidia can cause pulmonary aspergillosis. So the underlying factor in invasive pulmonary aspergillosis, IPA, or invasive bronchial aspergillosis, IBA, is an insufficient immune response which promotes development and invasion of the fungus. Another thing worth mentioning here is that prior cavitary disease from another disease like tuberculosis could be the cause of chronic pulmonary aspergillosis. Another thing that I want to mention here is that the root cause of aspergillosis in allergic bronchopulmonary aspergillosis, ABPA, and severe asthma with fungal sensitization, or SAFS, is an allergic reaction towards the element of the fungi. The species that's usually associated with the allergy is the Aspergillus fumigatus. So let's move on and talk about rhinosinusitis, right? It's often contracted by inhaling conidia. It often occurs in immunocompromised hosts. That being said, immunocompetent hosts could develop granulomatous invasive rhinosinusitis. So Aspergillus flavus is often associated with rhinosinusitis. So now let's talk about other things, right? For example, cerebral. Aspergillus can actually reach the brain. It reaches the brain from disseminated infection or extension from contagious area. The contagious area previously mentioned are paranasal sinuses, mastoid, and middle ear.
Hello everyone, my name is Nimade Aprilia Bisisianti with last 3 digits of to the number 229. I will continue to explain about the etiology. Next is endophthalmitis. Aspergillus species may enter the body through cataract surgery, leading to fungal endophthalmitis. Next is osteomyelitis. Aspergillus can penetrate the bone in cases of severe immunocompromise through direct injection, such as intravenous usage of drugs or an infection through a surgical site. Next is cutaneous. Onychomycosis has an Aspergillus species as a cause, and nail damage, immunosuppression, and exposure to soil are the main entry points for this infection. And the last one is disseminated in other site. Infections that spread widely frequently start in one of the aforementioned sites in the immunocompromised host can also cause disease in other sites.
Let me introduce myself. My name is Amanda Petrona Theobald with last three digit numbers 108. Infection starts with the inhalation of Aspergillus candida, which is present in the urban environment. Most candida are eliminated by ciliary mucus. Only a small amount of it will contact with the alveolar epithelium. Epithelial cells will activate actin-dependent phagocytosis, which is effective in eliminating Aspergillus candida. Less than 3% of the intracellular conidia will germinate and penetrate the epithelial lining without causing analysis to the host cell. The entry of conidia will activate host response by releasing antimicrobial effector, which will trigger the innate immunity. The activation of phagocytes will form the inflammatory response to kill Aspergillus conidia. Alveolar macrophages will phagocyte the conidia via biogenesis and signal activate mechanism. Neutrophil will release cytokines and some reactive oxygen substance in order to eliminate the hyphae. Adaptive immunity plays an important role in preventing the invasive disease. Presenting cells with trigger T cell function in immunopathology of invasive and non-invasive disease. This disease will be able to be prevented in patients with incompetent immune system. In immunocompromised patients, the defensive mechanism is impaired, causing the Aspergillus candida to spread and form the invasive disease.
Greetings, doctor. My name is Gabrielle from Mustafa with my last 3 digits in the number being 118, and I'll be continuing about the pathophysiology of invasive aspergillosis. In immunocompromised patients, spores will develop into an active form called hyphae, which will disseminate to various organs as a result of the body's immunity failure. Aspergillus hyphae are long, thread-like structures that can penetrate the lung tissue, spread locally, and penetrate the walls of the alveoli, that causing damage to the tissue. Hyphae that have penetrated lung tissue will continue their journey by penetrating surrounding blood vessels. This causes the formation of blood clots, bleeding, and the spread of infection to other organs in the body through the bloodstream. This process can also cause necrotic pneumonia. When aspergillus invades tissue and blood vessels, the body responds with inflammation that can produce symptoms such as fever, hemoptysis, chest pain, and shortness of breath. This inflammation is closely correlated to aspergillus angioinvasion with thrombosis of blood vessels causing tissue necrosis, invading the arterioles and allowing spread to distant sites such as kidneys, liver, spleen, and central nervous system, causing serious complications and even death. I think that would be all from me. Thank you.
Thank you for the time. My name is Sarah Putri Bungaran with 078 as the last 3 digits of my student number, and this time I will explain about the treatment of invasive pulmonary aspergillosis. So in clinical practice, antifungals are used by considering the resistant profile of a particular aspergillosis species, the history of antifungal prophylaxis used if any, and the patient's comorbidities. Voriconazole and isofonazole and amphotericin B with its fatty formulations are first-line antifungal agents for the treatment of invasive pulmonary aspergillosis. To ensure therapeutic levels, voriconazole administration should be monitored for 4 to 7 days and changes in other drugs that affect levels. A broader spectrum of antifungal activity was demonstrated with once daily administration of isavuconazole than voriconazole. Its intravenous formulation wasn't found to have nephrotoxic and hepatotoxic compounds typical of other triazole intravenous formulations such as cyclodextrin. In addition, drug interactions are mediated by CYP enzymes and show linear and predictable pharmacokinetics, so therapeutic drug monitoring isn't required with isavuconazole compared to voriconazole. Treatment of patients with chronic pulmonary aspergillosis presenting with pulmonary symptoms and loss of lung function is performed by oral therapy with itraconazole or voriconazole. It should be noted that Aspergillus tertius and Aspergillus aleucus are resistant to amphotericin B, and caspofungin is the second line of IPA treatment. Adequate duration of IPA treatment is still an unresolved issue. According to IDSA, therapy should be given 6 to 12 weeks considering the patient's clinical conditions and respond to therapy. However, it is necessary to monitor serum biomarkers and perform radiology follow-up such as CT scans to monitor the therapeutic response of IPA. Maybe that's all from me. Thank you for the attention.
My name is Putu Nadia Andita Prasanti, and my last 3-digit number is 150. In managing invasive pulmonary aspergillosis, there are 6 approaches to ensure the best possible care for our patient. First is antifungal medication. As said before, the cornerstone of invasive pulmonary aspergillosis management is the use of antifungal. The first line drug is voriconazole, isofuconazole, and amphotericin B, and the second line is caspofungin. These drugs are specifically designed to combat the aspergillus infection. In addition to antifungal, supportive therapy including oxygen administration is recommended, especially for critically ill patients. Oxygen therapy is determined by the disease severity and is typically not used in mild case, but is common in moderate to severe case. For some patients with localized invasive pulmonary aspergillosis that doesn't respond to antifungal treatment, especially those with cavitating lesion or experiencing massive hemoptysis, surgical intervention may be necessary. Environment control, such as installation of HEPA filters, controlling airflow direction in patient room, and utilizing positive pressure ventilation room for high-risk patients are also recommended to reduce the nosocomial or hospital-acquired pulmonary aspergillosis. Next, patient immune system is fundamental in invasive pulmonary aspergillosis management. One such condition is neutropenia, characterized by abnormally low neutrophil levels. To address this, the administration of granulocyte colony-stimulating factors can stimulate neutrophil production and enhance the immune response. Lastly, regular follow-up, appointments, and imaging studies are crucial in monitoring treatment progress, especially in tracking the resolution of pulmonary lesions. That's all about the management of invasive pulmonary aspergillosis. Thank you.
My name is Arianda Bella Maitri Anjasrini with the 3 last digit of student ID number 188. So the conclusions for this literature review is that aspergillosis encompasses a range of fungal infections stemming from various species within the Aspergillus genus. The specific clinical manifestations of these infections vary based on the individual's immune system health and route of entry, which mostly from the inhalations of Aspergillus conidia that are present in the airborne environment with invasive forms primarily affecting those who are immunocompromised. In individuals with unhealthy immune system, inhaled conidia will be eliminated by the ciliary mucosa, and within the alveolar epithelium, they will be eliminated through actin-dependent phagocytosis mechanism. Otherwise, spores will transform into an active state known as HEPA, which can then spread to the different organs due to compromised immune response, resulting in spread of infections to other organs in the body through the bloodstream, causing clinical symptoms that lead to organ necrosis. Administrations of first-line antifungal drugs such as voriconazole and isofuconazole as well as amphotericin B are some of treatment for invasive for IPA. Supportive and non-pharmacological approaches such as oxygen therapy and installations of HEPA filter are some of management of aspergillosis. Due to the non-specific clinical presentations of invasive pulmonary aspergillosis or IPA, non-neutropenic individuals are also at a high risk of these infections in contrary to this condition, which primarily affect those with compromised immune system. Appropriate management is required based on the clinical conditions, the severity of the infections, and the antifungal resistance of the fungal species causing the infection.
We have come to the end of our group presentation. Thank you for your attention.